Ketamine has been in the news a lot lately, and there are a lot of misconceptions about how this medicine is used for the treatment of mental health conditions. Is it safe and effective? Is it addictive? Is it a psychedelic? What's the difference between ketamine and the FDA-approved depression medicine, Spravato? In today's episode of the Psychedelic Therapy Frontiers podcast, we discuss the history and clinical applications of these two medicines as we attempt to answer some of these important questions. For those of you who are new to the show, welcome. Psychedelic Therapy Frontiers is brought to you by Numinous Network and is hosted by me, Dr. Steve Thayer, and my co-host, Dr. Reid Robison. Just a few quick announcements before we get into the episode. If you're looking for comprehensive foundational training in psychedelic-assisted therapy that includes live online classes, experiential learning, and opportunities to connect with a diverse community of practitioners in the psychedelic medicine space, then check out our courses. We're offering 10% off select courses for PTF podcast listeners, so click on the link in the show notes or go directly to numinousnetwork.com/training, where you can use the code PTF10 for that 10% discount. If you've been listening to our show for a while, you've likely heard Reid and I talk about the psychedelic clinical trial work that Numinous Network does. If you live in Utah and are interested in being a participant in a psychedelic clinical trial, you can click on the link in the show notes or go directly to numinousnetwork.com/research to learn more about the trials we're currently running. If you'd like to support our show, here's how you do it. Leave a rating or review in a place like Apple Podcasts or Spotify. If you're watching on YouTube, you can like the video, subscribe to the channel, maybe leave a comment, and please share the episode with someone you think might enjoy it. Without further delay, here's our conversation today about ketamine, Spravato, the history, risks, and benefits of these anesthetic psychedelics. So, Reid, we get a lot of questions about ketamine. Yeah?
Yes.
We do, right?
Yes. Near daily.
We've talked a lot about ketamine on this show. We even have an episode that's probably one of our most popular episodes we recorded many years ago about how to prepare for ketamine treatment or ketamine-assisted therapy. So ketamine is often included under what has become kind of a broad umbrella of psychedelics. And I guess there is some debate about whether or not ketamine should be included under that umbrella. What do you think? Is ketamine a psychedelic?
I like the classification these days that includes ketamine and MDMA, for example. And sure, we still need to define classic psychedelics based on this like common serotonergic mechanism, for example. But if you think about what psychedelic is, to wander in the mind or however you define it, ketamine certainly can be a tool for that. And in fact, it's a fun question because I remember discovering that the first writings on ketamine and its psychedelic use comes from this book written by a lady named Marcia Moore. What's it called? She wrote Bright World, Journeys into the Bright World. And I'll read you a little quote because I think it's cool. 1978. Why are the mind-manifesting drugs still regarded with so much fear? Can it be because modern science still lingers on the threshold of the unconscious, hesitating to knock too loudly for fear of what might be revealed if the door should open?
That's awesome. That's very poetic. Mind-manifesting drugs. There you go. Psychedelic, right?
Yeah. Yep. And it was around that time, earlier actually, 1970, this dude with a cool name, Ernst Ungerwich. I don't know how to pronounce German things, but he's the one who coined the term psychonaut, which meant sailors of the soul, or seekers of altered states of consciousness to search for truth in the unconscious mind.
Mm-hmm. Yeah. So to your point, ketamine occasions a altered state of consciousness that is shares a lot of features with some of the so-called classic psychedelics, but has different mechanism of action, and the phenomenology of a ketamine experience does have some pretty reliably reproduced differences from something like LSD or psilocybin.
And like many things, it's very dose dependent.
Right.
Like you could call cannabis a psychedelic, perhaps at a certain dose, perhaps at any dose if you really wanted to. Mm-hmm. But ketamine means a lot of different things at different doses as well, because given the mechanism, as the dose increases, like one piece of the mechanism might be this like calcium gated channel activity, letting ions into a cell, where as the dose increases, this activity increases, slowing down the thoughts and basically like flatlining certain like ordinary consciousness brainwaves, where there was even this sheep study of ketamine where you could almost pause consciousness on some of these EEG measures by increasing the dose.
Yeah, and if you increase the dose high enough, it flatlands entirely, and you lose consciousness.
It's an anesthetic.
That's why they use it in surgeries. But at much lower doses, it's a analgesic, right? It's a painkiller.
And anesthetic usually means scary drug because you need to support someone's airway. But in the case of ketamine, it was why it was developed. It was because it was anesthetic without airway compromise, or without needing to intubate someone. And it came after PCP flopped. Like PCP was developed like in the 1920s by the same company, Park Davis, but and used for quite a while in anesthesia, but people came out thrashing, like psychotic. And that still, it was still used after its ban, or after it was discontinued, withdrawn from the market. It was continued in street use as angel dust, and resulted in a lot of ER visits and psychiatric hospitalizations because there was a high rate of psychotic emergence.
Right. Yeah, I'm glad you're talking about the way ketamine's been characterized, maybe even in contrast to PCP, because it's in the popular media right now. We have the tragic death of Matthew Perry.
Yeah.
We have, all the attention that Elon Musk is getting and the accusations that he's high on several things, including ketamine. And so people will say, like, that's that horse tranquilizer. And sure, ketamine's been used in veterinary medicine, but also been used on the battlefield with combat medics, and used in ERs every day across the country.
And I think that's, if we were to really try and pinpoint its psychedelic origins, I think it comes from the Vietnam battlefields, to be honest, because it was used out there because of its uniqueness as a compound that didn't need all this airway equipment that could be an anesthetic in these places of severe physical trauma, like the battlefield. But then those who started to get to know it and have it in their backpacks started to use it. And I remember reading this term once. They were escaping exploring one's mind, but escaping one's trauma. Like it was used as those two things. Escaping one's trauma may or may not feel like a good thing to do with one's trauma, but we could talk about that. But sometimes you could see the value of a pause or time out from these things, but you can also see the appeal to keep checking out.
Right. And that's pretty consistent with how ketamine is sometimes referred to as a dissociative anesthetic, right? That it does tend to produce this disconnected feeling, whether that's from body or normal consciousness. And, dissociation is also a symptom, like a defense mechanism for people that have experienced trauma, where they just sort of disconnect. Understandable defense mechanism, but also might perpetuate the disease state, so to speak, because we want them to be in contact and move through what was traumatic. But I find it hard to fault somebody from wanting a break from their trauma, right?
Yeah.
And that could be therapeutic.
And if we're all being completely honest, we all dissociate or micro-dissociate at least all the time. Like it's kind of a natural wiring to withdraw from the pain. And, it happens in little ways and bigger ways, like the examples you mentioned. But
Right. So ketamine used in a variety of medical and psychiatric contexts. Nowadays, it's being prescribed off-label for the treatment of things like depression. And it comes, in the form of a ketamine clinic, or that you might go to, that's giving you a sort of hooking up to an IV and hoping it treats your depression and then they wish you well, or in a psychiatric or mental health clinic where it's being given in conjunction with psychotherapy. So we have ketamine-assisted psychotherapy, or ketamine-assisted therapy, sometimes abbreviated as CAT or CAP. And then also in the form of Spravato, which we wanted to talk about today, kind of comparing and contrasting racemic ketamine and the FDA-approved nasal spray for treatment-resistant depression and major depression with suicidality.
Yeah, this will be a fun kind of walk down memory lane a bit with our experience building up the clinics, the ketamine and the Spravato practice at Cedar Psychiatry. But even rewinding further, I remember when I started med school, and this will date myself to 2001. I started.
God, you're so old,
and
Reid.
thanks.
Not much older than me.
And so that's right after one of these, I think the first landmark study. It was Berman at Yale, who just published his ketamine for depression study in the year 2000. And it was a researcher in the 80s, 90s, Dr. Skolnick, who was a glutamatergic system researcher, started to hypothesize that ketamine and other NMDA receptor antagonists could potentially be beneficial for depression. Then boom, you have this Yale study. And right after I finished med school in 2006, I'm in psychiatry residency. Zarate at the NIH replicated that, did another IV ketamine, 0.5 milligram per kilogram over 40-minute protocol for depression. These studies did 2 or 3 times a week for 2 or 3 weeks, and then measured people's depression scores on the MADRS, like all the depression studies we do as well, including psilocybin studies. And the whole field was like, wow, like this is the first rapid antidepressant activity we've been able to put a finger on, and you didn't even have to take it home as a pill. Mm-hmm. And so it got kind of psychiatry's attention big time, to the point where, so I do my training, research fellowship, and started doing clinical trials at the University of Utah. And just when I was leaving to set up my own clinical trial shop, I was getting a bit impatient with like the turnaround time of IRB and contracts at the university, and just wanted to do it more efficiently. And that's when I got my first ketamine study. It was Johnson & Johnson said, we're studying IV ketamine for depression. I was like, whoa, weird. Like it's already out there on the market. But then it makes sense now looking back on, they were doing essentially validation of the Zarate and Berman work. Mm-hmm. And then they did a study to see, okay, do we need 2 or 3 times a week? 2 times is good enough, is fine. And then they looked at what can we do to the molecule to make it more deliverable in psychiatry, aka a nasal spray, and make it patentable. Because for better, for worse, or perhaps sadly, in our system, it's very incentivized by these patent protections, or else why is a drug company going to invest in it?
Right.
And how else are you going to do the work? Another topic and another kind of messy situation perhaps. But so then they make esketamine, this 1 enantiomer of ketamine, into a nasal spray that approximated the dose of that IV 0.5 milligrams per kilogram of ketamine, based on like receptor occupancy and whatnot. And then they did the Spravato studies, and it took all the way until I did that first study in 2011. It was 2019 that Spravato was approved for treatment-resistant depression. Yeah.
Yeah, that's there's not many people that could give that kind of thorough history. You've been involved in the esketamine journey quite intimately for a while, yeah? Yeah,
including when you and I were office mates, next door neighbor offices in Springville, the first Cedar Psychiatry Clinic that I had co-founded with our friend and former business partner, Seneca, who, this is what, 2017?
Yeah.
And we offered ketamine, mostly IM, sometimes IV, sometimes sublingual, intranasal, in this model that's still being done of 4 individual treatment bays, a central monitoring station, which is usually staffed by an MA or a nurse and a prescriber, like a PA, MD, NP, in psychiatry. And then so we were doing this ketamine and ketamine-assisted psychotherapy work alongside the regular med management psychotherapy, TMS. And then along comes Spravato, approved in 2019, a year or 2 later. And we had this busy ketamine practice, and we had no idea what Spravato would look like as far as reimbursement goes, but pretty cool that you have this FDA approved option, because we were using ketamine off label, meaning The doctor is going out on a limb, like doctors often do. 20% of prescriptions are off-label, they say. Go out on a limb and say, I'm using this med approved for something else. In this case, it's a big leap from anesthesia to psychiatry, but based on evidence, I'm prescribing at this very low dose in this setting for depression. And there was a little controversy about that, but I think we've even published data on this. It has been a life-saving tool for so many people. Along comes Spravato. We make the decision it's the right thing to offer it, and use people's insurance wherever possible and help figure out this world of billing codes and whatnot. And so we did. In the first year, we maybe had 2 clinics or so. Then the first year, I think we did 500 doses in 2019. Not bad, but then it quickly grew, and by year 2 or 3, it overtook the volume of ketamine because people could use their insurance. They didn't have to pay out of pocket, and because it was this trusted on-label option. And there is a lot of difference in opinion on ketamine versus Spravato among prescribers who all have their own biases, right? Mm-hmm. And sure, you get more flexibility in the dose range of ketamine, but there's also something to be said, and we've published this from our clinic data on esketamine outcomes in the real world, is people show up and they can access the number of treatments needed to get to a good place, remission, response from depression, and they can access it in an individualized maintenance program when it's covered by their insurance and they don't have to pay whatever the price is. Like, we put our prices as low as possible, like $225 a dose of ketamine, by far in the very low end of the range in the country, but still that adds up. Yeah. And I'm rambling here, Steve, but
no, I'm taking mental notes because I'm thinking about the clinicians in our audience who might use ketamine in their practice, particularly the therapists, right? In the form of ketamine-assisted therapy, where the treatment model might involve some preparation sessions. Maybe this person gets prescribed sublingual or intranasal ketamine. The therapist is sitting with them during the experience, a real psychedelic-assisted therapy model. And then they think about, or they hear about Spravato. Here's a prescribed drug, maybe like a psychiatric approach, meaning they've got major depression. Here's a drug you take that's supposed to treat the neurochemical imbalance that accounts for your major depression. And it doesn't happen in the context of psychotherapy. These are some of the biases that people might have in their mind about how Spravato is administered to folks. And so they might feel a little skeptical about Spravato, esketamine. So I thought it might be fun to kind of talk about the ways we tried to tackle that back in that day to provide people with psychotherapeutic support who, for financial reasons or otherwise, were choosing Spravato when they had the option of both.
And maybe I can try, and probably unsuccessfully, to pop this bias bubble a little bit, because ketamine entered psychiatry in the same way Spravato did. In the sense that it was studied as a medicine without psychotherapy paired to it, because there was not a paradigm for medicine-assisted psychotherapy before this current renaissance, before the current kind of wave of psychedelic phase 2, 3 clinical trials, and things like MDMA-assisted therapy going up for potential approval. So ketamine came into the field like that, but as an off-label drug and as something that was kind of had this relatively slow rollout over the last decade, 5-10 years, that you'd see in more and more mental health clinics, and even some pop-up clinics just to offer that. Like, I remember being taken aback a couple years ago at the grocery store, looking over, and in the strip mall, it's like a pharmacy had a sign of now offering ketamine injections. I was like, whoa, what's the setting like there?
Yeah, or the Botox clinic that also offers ketamine, and
in lots.
You can get a chemical peel at the same time.
And to be honest, that was a part of why I left my stable, enjoyable post as kind of medical director at Center for Change back in 2017 to start Cedar, is because I saw these things popping up. There was one clinic that was really troubling in particular in Salt Lake City that I was aware of, and doesn't exist anymore, thankfully. But but I felt like this needs to be out there in a good way, like a good, safe, effective way. And in my opinion, it should exist in this container of mental health support wrapped around it. And the easiest way to do that is within a mental health clinic, especially one where there's both med management and therapy at the same time. Yeah. And so that's what we did. Not that the clinics were started to offer ketamine, but part of the impetus of like, why another clinic or why go into outpatient? Because there was a bit of a call to action that I felt.
Yeah. I remember lots of conversations about this, sort of your inspiration around doing the clinics that way early on. And so when we'd have the conversation about Spravato, how can we offer people who are getting Spravato that psychotherapeutic support? So we had a couple of ideas. One of which was we offered a group, it's like kind of like an integration group for anybody receiving ketamine and or Spravato treatment.
Every week, yeah. Yeah, we'd do it in my office or then yours for most of the time. Yeah.
Yeah, and it was well attended for the time that we did it. And we had people in there who were, getting ketamine injections and people who were doing the Spravato nasal spray. And I remember just sort of taking note and observing the qualitative similarities and differences that people were reporting. And, again, this is just N of a few with the clients that I saw, but it seemed like the people who were doing Spravato tended to have less of a psychedelic experience than the people who were doing ketamine. And again, that might be molecule or it might be dose, because the dose ranges that you have access to with Spravato are limited by the REMS.
Yeah, and I think it is dose and route of administration, because what Janssen did was take ketamine, which is the mixture of the R and the S enantiomers, like molecules have this handedness, if you will, or this right and left hand. And so esketamine is the S enantiomer of ketamine and happens to be like, and there's a lot of ways to talk about potency, but 3 or 4 times more potent in terms of affinity for NMDA receptors, making it kind of possible for them to do this in a nasal spray, perhaps, but still the subjective effects are, usually quite different. Maybe not if you were doing nasal spray ketamine, though.
Yeah. And those subjective effects being, a little bit of a relaxation of normal thought. Like you mentioned, it slows down thought, which can open you up a little bit, can be a break from normal thinking. Some people still have sort of the dreamlike visions that we might expect from a higher dose of ketamine.
Yeah.
It's the insights. For some folks, it's just floating around in inner space, and there's not anything particularly insightful, but often a break, like we're talking about.
Yeah, and there's some papers that have really described it well. I wish I used to know the author and year quite well, but this paper from like a decade ago that talks about the phenomenology of the ketamine experience. It calls it a non-ordinary state of consciousness, which I like. Altered state, same thing, but non-ordinary for whatever reason, I think is cool. And but it talks about how it's like, at the psycholytic doses or the early low doses of it, it's like you're describing a slight kind of loosening of our inhibitions and an opening of the emotional world. And it's interesting, at the same time, as the dose increases, there's a sensory kind of and physical dissociation, and it hits different parts of your sensory system at different times. Like your vision can go a little blurry, or the room can be spinning a bit at a certain dose, and then there's also like a numbness or whatever goes along with that anesthetic property that happens at the higher doses. But yeah, esketamine tends to stay in the lower realm of, some might even say, heart opening, but it does feel like still somewhat of a timeout from the ordinary ruminating mind that can be so taxing, especially in major depressive disorder.
Right. Yeah. So you can see by that description how, a course of treatment with Spravato would be very helpful for somebody with depression, even if they didn't have psychotherapeutic support. You can also see how those effects could be really useful to leverage in the context of psychotherapy with ketamine-assisted therapy. It also makes me think of, we mentioned how ketamine is sort of in the pop culture conversation, and there's concerns about ketamine abuse. I've made reference to some of the clinics that maybe online clinics that will prescribe lots of ketamine to people without a lot of medical or mental health supervision. And there's concerns about an unhealthy relationship to this drug.
Yeah. And so back to the walk down memory lane a little bit, like you were talking about in the pre-Spravato days, especially when we were trying to figure out how to help people access this, there were certain cases where we would do take-home doses. So people didn't have to drive an hour and a half, pay out of pocket, and get a second mortgage on their house or whatever to keep maintaining. So we came up with the best protocol we could at the time of like if there was a known caregiver to us and we can involve them and have everyone's agreement that there's someone to hold space for this and they've done it in clinic with us before, we know how they're going to respond. That's a good predictor. And so I think we were able to help a lot of people that way. And you could also see how occasionally there was someone who would like have an inclination to maybe use it a bit excessively or run out too quickly, and how Spravato has this check and balance in place where that can't happen. And I think it's worth explaining that when Spravato was approved in 2019, it came with what's called a REMS, risk evaluation mitigation strategy. And Accutane has a REMS, meaning you have to pregnancy test before you get your new prescription. So a REMS is something the FDA says, okay, we're going to approve this drug, but there are these safety measures that have to stay in place. Even clozapine for schizophrenia had a REMS requiring blood draws that was just like unmandated recently. So Spravato came with a REMS that said any clinics and prescribers need to be registered. The pharmacy giving it needs to be registered. The patients need to register in the REMS, and it can only be kind of shipped or delivered to the clinic, not the patient's home, and can only be given in clinic. Interestingly, the patient administers it while you watch, and there's a protocol for like, do a spray in this nostril, wait X minutes, do the next one, depending on your dose. And because of that, I can say we've never, and having given over 50,000 doses of Spravato by far in Cedar psychiatry clinics, now numerous, since it was approved, we've never had one incident of like a patient diverting it, or because they don't have their hands on it. Right. It's managed in clinic in this strict way.
Yeah. So, I mean, a clear, you could say, benefit of doing the Spravato route rather than the ketamine route.
Pain in the ass benefit, perhaps you might say. Like a REMS system means paperwork and stuff. But interestingly, the Spravato REMS has evolved as they do. Like I mentioned, a big clozapine change, but maybe a year ago or so, there was the requirement for pulse ox monitoring that wasn't previously on it. You had to check blood pressure, heart rate, things like that. But then pulse ox was added. But now the most recent change has been there's less, you don't even have to report the vitals anymore, like less paperwork perhaps, but still that same concept of registering everyone involved.
Right. Yeah. Right. So I think I'm remembering Phil Wolfson, the sort of so-called godfather of ketamine-assisted therapy.
And one of our mentors.
Yeah. Talking about this concern about, ketamine use disorder, I guess we could call it. People who are starting their ketamine journey in a therapeutic context and develop an unhealthy relationship to it. I remember him saying that he just hasn't seen that most of the people that he's treating in a therapeutic context with ketamine, even if they have some take-home ketamine, aren't usually developing an unhealthy relationship. I mean, it's certainly possible, but
I think because Phil has written, he's such a gifted writer too, and not afraid to speak up at his wise age, right? And so he's written about kind of the risks and the benefits, and done a lot to really, eloquently highlight the good way of offering this. And I've collaborated with him on several cases who, people who were traveling to Utah or moved here, and his protocol was pretty. He landed on a pretty strict and safe one in terms of if any take-home doses exist and how to keep it in a reasonable dose range within clinic. And where I've seen things go south with ketamine is when there's just the ability for someone to use it in a non kind of intentional way, like more access to it, because I think there's a subtype of people who are kind of primed to check out and are at risk for using it excessively that way, among other risks that we can talk about, like some, even psychosis perhaps.
Yeah, and I think that'd be true of any substance that has a euphoric or dissociative quality to it. If maybe increases the potential for abuse, where it helps them check out of the problems rather than going in and through those problems. So yeah, I mean, you see it on the dance floor, you see it at parties, you hear about the K-hole, people taking enough ketamine to sort of drop into that full dissociation and check out, and it can be dangerous. We've talked about on here the potential for is it interstitial cystitis or bladder problems with excessive ketamine use?
Yeah, it can be severe bladder problems with chronic high dose illicit ketamine use. And that was monitored closely in the esketamine trials because of that, and FDA mandated, I'm sure. And so interestingly, in the Spravato studies, there was while paying close attention to it, there was a bit of a signal in some urinary symptoms, no interstitial cystitis, no bladder, lasting bladder dysfunction at all, but some activity in the urinary system. But there are some people who have destroyed their bladder from ketamine and, ketamine and some of its effects there, among other things like long-term cognitive impairments. Memory, so like in the Spravato studies that was looked at, where they even did cognitive testing. They did it 2 hours, 4 hours post Spravato dose and during, and it was impaired during. We don't let people drive home or even that whole day, but the cognitive impairment was gone by hour 2 or 4, back to baseline, which, I might have guessed it would linger a bit longer than that. But I think ketamine in the right doses and protocol, and esketamine, because of the protocol that has to be followed, can be quite safe even in long-term use. And there is good data to support it coming from the open label Spravato stuff that happened after their trials that got it approved, showing that, if you continue getting it at some individualized frequency, say it could be every 2 weeks, for example, or less, or some more frequent, or even changing frequency a little bit, you can significantly reduce the risk of relapse into depression. So some people do stay on it at some interval.
Yeah, kind of what you referred to earlier as like a maintenance phase after initial treatment.
Because ketamine and esketamine are good, rapid antidepressants, but they don't last forever.
Right. Yeah, it makes me think of, we mention her all the time, but Gludolin's research on sort of that window of neuroplasticity and critical periods. And I think I remember seeing that graph. Ketamine was one of the shorter windows.
Yeah, it's funny. She pointed out, and we had been struck by that the first time we saw it, even before having her on the podcast, but it interestingly correlated to the half-life of a drug, where your 1 or 2 hour ketamine, esketamine might have a 1 or 2 day window of critical period opening up versus psilocybin and its 6 to 8 hour clinic session, 2 weeks LSD. Our phase 2 LSD, we were with people 12-hour sessions. Now it's less, but and Ibogaine, a 4-week window.
Yeah, you mentioned the potential risk for psychosis, and I just wanted to circle back to that because we talk about sort of doing an assessment and thinking about contraindications, inclusion, exclusion criteria for people doing any kind of psychedelic-assisted therapy, ketamine included. that when somebody's consciousness is already kind of loose and they have maybe a loose grip on reality, it might make sense not to give them something that makes it even looser. But I would imagine it's a pretty low base rate event when the screening is done thoroughly that ketamine is going to send somebody into florid psychosis.
And the same risk exists for classic psychedelics too.
Right.
A low risk, say less than a percentage chance of persisting psychotic symptoms after that day is over. But maybe to zoom out just for fun a bit, and you mentioned like the loose grip on reality. Like if you look at our brain on this spectrum of chaos to rigidity, or entropy to order, or loss of control to over control, and you start to plot yourself at any given time in your life on this spectrum, or plot certain types of conditions like schizophrenia high on the entropy end of the spectrum, or like inability to make sense and organize reality. But then on the far other end of the spectrum, you could have OCD, inability to loosen one's grip on the over control and the rules around how you've organized the world. And you have like anorexia, inability to let oneself eat, but bulimia on the other end, like inability to stop the cycle of binging, purging. And so you look at how some people, there's a lot of this in the cannabis literature, especially around adolescence, but some people are more at risk for psychosis. And there's even this prodromal period of early symptoms of this pre-psychotic weirdness and isolation, and maybe even affective flattening, or making up things that can start to show up. And I think it's that category of people, and even those where that's not even being manifest, there's an at-risk population where it can unearth it, and we don't have a good way to pinpoint that.
Right.
Yeah.
Right. So, I mean, based on what you said, it again kind of makes sense where ketamine use leading to some kind of psychotic break less likely to happen in a clinic context because we're doing thorough assessments. We're filtering those people out as best we can.
Yeah.
But also a testament to why it is really risky for sort of the general population in an illicit way to use especially high doses and frequent doses of ketamine, because you might be on that sort of chaos end of the spectrum and you're playing with fire.
Yeah. So it's a good point to zero in on what does this mean, or like how might we assess this in the real world? Because I get asked this question a lot of, should I go into this course of ketamine treatment or ayahuasca ceremony or whatever, given that my mom has bipolar, or that I have a personal history of XYZ. And the early studies with psychedelics, including studies with ketamine, now and then have excluded even first-degree relatives with psychotic episode from participating in the study. Like, we need to know what happens, but like what happens in the early phase of studies is they're more restrictive, and then that gets loosened as it gets closer to the real world. But yeah, I think the risk is low, and how do you know if someone is at risk? And I think we're talking about a couple ways of looking at your genetic risk, perhaps. Are there close relatives who have had these episodes of mania, psychosis, etc.? And how grounded do you feel in your life? I love this question that came from a difficult experiences panel at the MAPS conference 2 years ago by the Hopkins group, Yaden and colleagues, of like, before going into a psychedelic experience, how prepared do you feel, or how willing are you to let yourself fall apart? Or does that kind of seem catastrophic in terms of ability to piece oneself back together? And maybe you have some other ways of looking at this, but just like how grounded do you feel, and what's your safety net, and how much of an anchor do you have in yourself and in your supports if you're having trouble landing back on earth?
Yeah, I've actually been thinking a lot about this recently. I just today taught one of our fundamentals of psychedelic-assisted therapy course modules. This one was on assessment, where we're talking about some of these factors. and potential red lights, yellow lights, green lights for moving forward with psychedelic assisted therapy. And one of the things you assess for is this groundedness, this what gives them confidence that even if things did fall apart, they could put themselves back together. And certainly if people are just like totally grounded, totally ready, they've got all the things in place, you might ask yourself, well, why do they need therapy? Like,
is that over control?
Yeah,
are they going to be able to surrender?
Right. Yeah. It could be over control. So we want to give these treatments to people who need them most. And so you don't have to be totally secure and in order to get those treatments, but it does make sense. If we're looking at the risk of somebody who feels really unstable and not confident that if their psychedelic experience, in this case with ketamine, picks them apart piece by piece, that they could put themselves back together, is that a gap we can cross? Can we, through thorough preparation, bring them up to comfort and competence and trust and safety so that they can move into this with feeling prepared?
Yeah. No, I think it's really well said, and it's making me think of the parallel for the therapist listening, perhaps, the parallel with trauma work in general, where there's a general consensus that you need to do some preparatory work and really assess the situation from the therapist's eyes and in discussion with the client of, are you ready to go and do this work?
Right.
And I think that's something that's, they might be hard to quantify and pinpoint for many people or in many ways, but it's something that I think makes sense, and we're perhaps intuitively equipped to really listen to.
Yeah, the trauma work is a good example, because you talk about the window of tolerance, that as you're working with somebody with trauma, you might sort of pendulate out of that window of tolerance for exposure and for stretching their comfort zone, but you want to find ways to return to it so there's a sense of stability and safety. When you add psychedelics to that mix, there's the possibility, because we don't know exactly what's going to happen, that a psychedelic experience swings somebody pretty far outside of their window of tolerance. So again, do they have the internal and externalized resources to help bring themselves back with your support into a window of tolerance so they don't feel like they've, are too far on that entropy end?
And it's interesting looking back at this spectrum to just think about how psychedelics, broadly defined, ketamine included, can be useful for conditions at either end of the spectrum.
Yeah.
And why is that? And I can think of so many people where ketamine's been a useful tool to go in, starting low, going slow, and really hand-holding because they've had a lot of over-control and struggle surrendering, or because there was, on the other end of that spectrum, a propensity to fall apart dramatically and so quickly. And there would occasionally be some wailing coming from, a private ketamine session where we're not doing these in the main, room anymore, even if they're separated by walls or whatever, and taking it into a private cap session, but still some people, it opens a door for things, a floodgate of things to spill out.
Yeah. I mean, one of the many reasons that psychedelics and ketamine are such interesting tools, that you have the same chemical can act differently in different brains on either ends of those spectrums and be helpful. It's kind of like I don't want to overstate the benefits, but like a little Swiss Army knife of psychiatric intervention.
Yeah, and I've heard it called that. And I have got the question from countless clinicians in our clinics and elsewhere of, can I use ketamine for this condition, such as severe PTSD, dissociative identity disorder, bipolar with a history of maniopsychosis or
borderline personality disorder.
Yeah. And these conditions that have a loss of control end of the spectrum, perhaps, or a little too close to the entropy side. And if you look at the ketamine literature, first of all, ketamine was used even before it was in depression in psychiatry as a model of psychosis.
Yes.
Before one of my early ketamine studies that I got involved with was a study of that. It was giving ketamine, then testing an antipsychotic on that state of consciousness. Not a perfect model, but there have been a number of papers written on like what happens when you give ketamine to someone with schizophrenia or with psychosis. And I think the short answer is the experience can be a little bit more dramatic. Like, you know, you might blast off into that dissociation and psychomimetic land a little more quickly, and maybe its peak might be a little higher, and it may last a little bit longer, but there's no real difference in like coming back to your baseline in those studies. Like, I'm not encouraging its use in any of these conditions. In fact, what we landed on is all those conditions require more wraparound support and more careful attention, because it can be more pronounced.
Yeah. I mean, you know the literature better than I do, but I don't know that there is a ton of literature out there on using ketamine for those conditions. Most of it is for depression, maybe anxiety, more trauma literature coming out.
Yeah. And the ones, I mean, there are a few case reports of ketamine for like helping resolve certain psychotic type symptoms. But the studies I was alluding to were more in an experimental mode. Like, what's the difference of this state of consciousness when we give it to, like, they got ethical approval to test it on individuals with psychosis to see what happens.
It wasn't really
because it's an anesthetic.
Yeah.
And it has all these other uses and reasons to test it in lots of populations, and a lot of there's a lot of decades of ketamine use that predated its entry into mainstream psychiatry. In fact, I remember after the first time I gave ketamine to a patient was when I was in like my intern year rotating at Primary Children's Medical Center, where we would give IM ketamine to kids before like setting a fracture or suturing, because otherwise they would not hold still enough. And,
understandable.
And then fast forward a bit, after that first ketamine study for Janssen back, say 2011 to 2010, I applied for some funding from the Intermountain Foundation to study it for suicidality, and was setting up that protocol. But at the same time, I was running the consult service at the biggest hospital in Utah, IMC. And I would consult on these severe cases of depression, anyone in the hospital, say after an overdose or with serious medical stuff, who had psych needs. And there were many cases where I was like, I need a rapid antidepressant, and I know one, and I just studied one, and it was pretty remarkable. But I don't know how to, like, I've given it, but I don't know, can I give it? Should I give it? So I remember one really memorable case talking to the it was like the ICU floor or post ICU, where like I'm like, I have this crazy idea, and cited a little bit of literature and said, what do you think about giving this little dose of ketamine to this gentleman? And they're like, yeah, you want to do it right now? Here you go, let's go. And we did. And then it became more like, it became useful in the ER. It became useful to help bridge someone to another antidepressant or course of therapy. And for a while, we even had a regular space in the infusion center at the Huntsman Cancer Clinic there at IMC, where we could have some people come in for twice weekly treatments, and we're able to like turn off their vagal nerve stimulator or pause the course of ECT they were doing. But I remember the nurses in that infusion center calling me one day saying, you know, we think you should send your own nurse over here because your patients keep crying and we don't know what to do.
We don't know what to do.
Yeah, I mean, they were amazing nurses, and
course,
jokingly, but they were like, it's just different.
Yeah.
Than the chemo in the chair next to it.
Sure. Yeah. Such an amazing tool, and this story kind of makes me think of maybe the next frontier for ketamine research. You know, we back at Cedar Numinous, we also had TMS available, which you mentioned, and there's some interesting ideas about the combination of the two, ketamine and TMS, or ketamine and other treatments.
Yeah.
And whether or not that might be effective.
And TMS is such an intriguing thing. Like, I'm just in this reminiscing mode, but I remember like watching that in med school residency and kind of being mind boggled at this futuristic space helmet that you could put on and tell pathway of neurons to fire repeatedly. And then it's been approved for depression for quite some time, but just wasn't really gaining insurance traction until more recently. But the way it works is you have this like MRI strength magnet in a helmet or coil right by the head, aimed at a certain part of the brain. In depression, it's the dorsolateral prefrontal cortex on the left side. You aim it there. First, you test that your strength is high enough by aiming it at the motor cortex that moves your hand, and you make sure you know the strength of that firing of TMS that will make the hand twitch. And so then you're like, okay, we know what's going to fire neurons. Aim it at the depression area. Hope you're right and everything. Yeah. And then you do it 2,000 times in one session-ish. So you're firing the positive mood pathway over and over. And then you say, come back tomorrow for 20 minutes, 2,000 more reps. You do it 5 days a week for, say, 30 total sessions. And the data shows some improvement, some lasting like sustainability of these positive mood pathways.
Yeah. I was listening to an episode of Tim Ferriss's podcast, and he's been pretty public lately about using rapid TMS for his OCD. And he talked to Nolan Williams about TMS, and his report is that it's generally been pretty helpful. He did have some negative experiences with follow-up treatments, but that's where you're coming in for like 10 hours, and they're giving you a 20-minute treatment every hour or so for a long, long time.
Does Tim have one at his house now, I wonder?
He actually cautioned against like these DIY TMS helmets where people are hurting themselves or burning themselves.
Yeah, there's a lot of DIY tech out there, like TDCS and other stuff with some interesting evidence too. But the OCD use of TMS is kind of cool, because I remember when we started offering TMS in our clinics, it had been approved for a while, but for depression, we were giving it for depression first, and we could do some off-label stuff like PTSD protocol, headache protocol, whatever, that we'd sometimes do. But then OCD approval came. And so we got the helmet to treat OCD, and the protocol for that was different. You're aiming it at a different brain area and setting the parameters a little differently, but you're also doing this distress script where in the preparation for this, you're finding out more about the obsessions and compulsions. Let's say someone has a severe fear of germs and toilet seats or whatever. When they come in for a TMS session, you're having them visualize that very distressing place of like germs on the toilet seat or licking the toilet, like whatever, to get their distress level up to a certain amount. And then you hit the button on TMS and you modulate it from there. It's really interesting.
So fascinating. Yeah, this mechanistic approach to mental health is really fascinating to me. So I'm wondering if we could cap off the Spravato ketamine discussion with just briefly talking about a comparison of the two. We were talking about this a little bit before we recorded. I mean, there's some meta-analysis, I screwed it up before that too. Meta-analytic studies, how about that? That compare available data, but I don't know, and if anybody knows differently, and like let us know, but I don't know if there are any actual head-to-head comparisons.
I have not found one yet. I keep a best pulse I can on ketamine and esketamine literature. And there's a lot coming out, but to my knowledge, no one has funded a prospective head-to-head comparison of the two. And therefore, it's taken the statistical wizards to bring it into the meta world of meta-analyses to extrapolate, the best p-value we can from there.
Yeah. I think one thing I found, there was like a proposed protocol for a head-to-head RCT, but I don't think anything ever came of it.
Yeah, interestingly, there was in Europe an esketamine versus Seroquel XR study that is fun to draw on some kind of comparison, because these are unfortunately not often enough done. They're not incentivized. They're disincentivized or perhaps seen as counterproductive by pharma companies who are working so hard to get patent protection for the life of this new drug for this specific condition, where the FDA is saying, just show us that it separates from placebo, and we're going to make sure this is a meaningful addition to the field. But no one's studying the two until you have things like STAR-D, NIH funded. That's not a pharma study.
Right. Yeah, the best I can do is some anecdotes from some of my clients who've tried both. And, it's the jury is still out. Some of them felt like regular ketamine was more helpful than Spravato, but also vice versa. Controlling for the different ways in which it's administered and whether or not it's with psychotherapy.
Yeah. So I mentioned this briefly, but we published, I'd say, 3 relevant papers from our Cedar Psychiatry Numinous Clinic data on this topic. One is the real world outcomes of people who got ketamine. And this is retrospective, like looking at a certain year of clinic data and looking at the PHQ-9 scores that they filled out and trying to make sense of it, this noisy real world data, and show, okay, positive outcomes, good safety, tolerability. We did the same with esketamine, not a head-to-head, but they both looked similar in their benefit. And I think for slightly different reasons, but then we did one paper that was a cost effectiveness comparison from like the real world or patient perspective of the two, and showing, esketamine versus ketamine in that regard. And that's a whole nother statistical kind of task to try and, what do you use as your model for that? But point is, after all those, they're both useful, like you said. You kind of need in an individualized basis, and I've had many people go from one to the other, back and forth, or even once in a while had to insert a ketamine dose into the middle of some other protocol, whether it's TMS or esketamine. But I think you have what we said earlier, the flexibility of dose and frequency with ketamine, right, but more of a reliability of accessing it in a kind of minimally effective protocol way with Spravato.
Yeah. I lied when it says it'll be the last thing we talked about, because something else you said, the comparison of Spravato with antidepressant. One of the things that's nice about ketamine compared to classic psychedelics is that it plays pretty well with other medications people tend to be on.
Yeah.
So, tell me if I'm wrong about this, but you can be on your antidepressant and do ketamine, and it's unlike with something like psilocybin, where maybe your antidepressant might potentially blunt the effects because of similar mechanisms of action. Ketamine is, generally plays well with those things.
Ketamine plays well with other meds, including, and maybe even contrary to popular belief, and this will require a disclaimer, even with like benzos, or like there's some data on like those smoothing the negative aspects of a dissociative experience. Not that we recommend that strategy, but I'd say the areas of caution are with sedative hypnotic drugs, including benzos, muscle relaxants, anything that might slow down your respirations, like opiates, even though there can be kind of a synergistic, problematic combination of some of those things with ketamine, if not well managed. And then also like coming in with cannabis or anything else that might put you on the end of that spectrum, at risk for dissociating more extremely or in a prolonged way, you got to know about. But there are a few things like lamotrigine, Lamictal, for example, that is thought to blunt some of the effects of ketamine. And so you'll see some prescribers out there, when they see that in a paper or two, might be considering either stopping Lamictal or not starting it until after trying this ketamine course, or not escalating the dose that you plan to anyway until you see, because it doesn't blunt it in a predictable, reliable, universal way, but it can interfere, but not the antidepressants as far as we can tell.
Yeah, super interesting. Well, we've covered a lot of ground. Hopefully that was useful to you folks, talking about ketamine, Spravato, and the like.
It's been fun to chat with you about, Steve, so thank you.
A little bit of memory lane, too. It's fun.
Until next time.
Hey, there you go. Psychedelic Therapy Frontiers is brought to you by Numinous Network, a company committed to helping people heal and be well by delivering technology-driven clinic support, clinical trial research, and comprehensive practitioner training in psychedelic-assisted therapy. You can learn more about Numinous Network at numinous.com. That's numinus.com. If you enjoyed the show today and you want to support us, here's how you do it. You can leave a rating or review on places like Apple Podcasts and Spotify, subscribe to the Numinous YouTube channel, like the YouTube videos, and share the show with somebody you think might enjoy it. If you're interested in comprehensive training in psychedelic-assisted therapy, check out our courses at numinous.com/training. These courses are carefully crafted by Numinous professionals like myself, Reid, and others, and include live online classes, experiential learning, and opportunities to connect with a diverse community of practitioners in the psychedelic medicine space. I really love teaching these courses and connecting with you all, so check out numinous.com/training, and I hope to see you at the next training cohort. The content of this podcast does not constitute medical advice or mental health treatment. Please consult with a medical or mental health professional if you believe you are in need of mental health treatment.